Welcome everybody. This is Jeff Usher, Program Officer at the Kansas Health Foundation, and this is our Healthy Communities webinar. And as many of you know, back in March, when we convened the Healthy Communities, one of the things we heard loud and clear was how do we put a health equity lens on our work. So the technical assistance team has been working hard trying to find someone, and I'll let Adrienne take over with some housekeeping items, and then she can introduce our speaker today.
Great.
Adrienne?
Thanks, Jeff. This is Adrienne Payne-Andrews, Project Director for the Healthy Communities Initiative. Just a couple of housekeeping items before we begin. All of your phone lines are muted to reduce background noise. Please use your audio pin so that your lines can be unmuted to participate in a discussion later in the webinar. Please make sure your computer speakers are turned off or muted to help eliminate any background noise. The webinar is being recorded and will be archived on SharePoint. Time will be set aside for questions at the end of the webinar, so if you could please type any questions you have in the chat box on the right side of your screen, that would be great. We will close with announcements about some upcoming events and due dates. With that, I'm honored today to introduce our speaker, Stephanie Borden, Associate Director with PolicyLink. Her work focuses on promoting social and economic equity through environmental and policy change, particularly in low-income communities and communities of color. Thank you, Stephanie, very much for putting this webinar together for us. And with that, I'll go ahead and turn it over to you.
Great. Thank you, Adrienne and Jeff. Good afternoon, everyone. First, I just want to start by thanking the Kansas Health Foundation for inviting PolicyLink and myself to speak with you all today. I'm really looking forward to sharing some of just our thinking and experience with you all, and then opening it up at the end to respond to any sort of questions you may have, any challenges or concerns. So just to give you a sense of flow for our next kind of hour together, I'm just going to start by sharing some definitions and terminology to really ground us all in a common language so that at a minimum you kind of understand what I mean when I'm using the words that I do with you all today. Then I'm going to move into sharing PolicyLink's framework for how we think about the way in which race, place, and health really intersect. And then I'm going to want to, I'm going to lift up a couple of examples to really help illustrate the concepts that I will be discussing with you all today, and then just end with some points for consideration for you all to kind of keep with you as you think about how you will apply an equity lens to your Healthy Communities work. And throughout, you'll hear me kind of offer up some probing questions and ways in which that we as PolicyLink really try and reflect on our work, and then also how we encourage others to. So as Adrienne said, if you have questions, please feel free to type those into the chat box so that we can capture those and make sure to come back to them at the end of the presentation. So a little bit about PolicyLink. We are a national research and action institute that really works to advance economic, social, and racial equity by lifting up what works. And this tagline, lifting up what works, really is a reflection of our belief that local leaders and local strategies are really kind of building blocks for the solutions that our nation will really need to be putting in place. So really, you all are working deeply in place, and what works for you is really what we believe needs to be lifted up and shared nationally. So within PolicyLink, I'm actually located in the Center for Health Equity and Place. We also have a Center for Infrastructure Equity and a new Center for Cradle and Career. But in the Center for Health Equity and Place, we really believe that where you live affects how you live. And that your health is really more than just the absence of disease. So when I'm talking about health, I'm fundamentally talking, we take a broad example, and I'm really talking about one's overall state of physical, economic, social, and spiritual well-being. So when we think about health equity, oftentimes I feel like it can be a stretch to kind of just go there. So I'm going to back into it and start by talking about health disparities. And so health disparities this is a term you all are probably familiar with. And really, these are differences, right? Disparities are differences. And so we oftentimes are keyed into the way in which health is unequally distributed amongst our populations. So we usually look at differences in health outcomes by race, by socioeconomic status, sexual orientation, gender, disability status, also locations, right? One county may have overall better health outcomes than another county, and a combination of these, really because we all live our lives. We all have multidimensional lives, right? So I both experience the world as not only a Black person in America, but also as a Black female who lives in a very urban city. But we know that we can't just stop at understanding health disparities, because understanding the differences in outcomes isn't enough. In order to really address these differences, we need to understand and focus our efforts toward what is causing the differences that we see in health outcomes. And that really takes us a step further to really look at inequity, leads us further upstream to look at what the inequities are that really underlie the differences in health outcomes or disparities that we're seeing in our communities. And these inequities are also often referred to as the social determinants of health. So this idea that our environments really either facilitate or create barriers for us to experience kind of our highest potential for health. So here you'll see kind of two trees, and I like to use this visual because it's a good way of thinking about communities like those on the left, which have high inequities and are kind of low in community assets and therefore have poor health outcomes, and communities on the right, where inequities are low, assets are high, and health outcomes are generally better. And so if you focus at the top of the tree, in the underserved, kind of under-resourced community on the left, you'll see that those people living in that community are experiencing kind of many things at once, right? So there's substance abuse, there's violence, there's poor nutrition, that really they're facing the cumulative impacts of all of these. And that the same people we want to see getting better that often have trouble kind of achieving their optimal health are dealing with some of the same things, right? They're dealing with poor school quality, high rates of infectious and chronic disease, and therefore are not really able to experience the benefits of a stable environment. If you go down and you look at the trunk really represents population behaviors and characteristics. So on the left, you have a very thick trunk, and you've got a strong sense of community. You've got strong social networks. Folks are participating. They're civically engaged. You've got your local leaders that are really visible, and you've got networks and partnerships and organizations that are really organized and connected and working in concert with one another. And then on the left, you'll see you've got fragmented systems and a sense of powerlessness, and there's not a lot of investment happening. And then members of the community may feel really disconnected from one another. So then you go down to the roots, right? And the roots, you'll see on the right, they're thick and they're deep and they're expansive. And then on the left, there are less roots and they're thinner and they're not as expansive. And so in the unhealthy tree, these are the community conditions that are really underlying the health inequities that we see. So what you see underground in the healthy neighborhoods is really kind of, those are the assets. Those are kind of the invisible privileges that folks experience without really thinking about it. But I think one of the key takeaways for this visual is that it's not that people in the affluent community aren't dealing with HIV or substance abuse, right? It's just that these things haven't become dominant because there's a sense of balance. that in opportunity-rich communities, thriving environments provide other supports that really help support healthy behavior and healthy lifestyles. And so that the community assets are really enabling folks to, the majority of folks, to really make healthy decisions and really give them options to reach their optimal health. And because communities don't exist in isolation, therefore we as practitioners, as people who really are concerned with improved health and improved stability and improved outcomes, we need to look at the environments in which our people are living. So another way of looking at this is that when we think about building communities of opportunity that support people in their attempts to live a healthy lifestyle, we do have a sense of which characteristics are key, right? So we've got the low-income communities on the right in this visual, and then on the left we've got these communities of opportunity. These are the community characteristics, not an exhaustive list, but some of the key ones that I know you all are focused on that really lead to good health status. So we've got safe parks, we've got an affordable, accessible grocery store, right? Well-performing schools, financial institutions that are lending to folks, small businesses, potential homeowners, and we've got good public transit that really keeps us connected to jobs, to recreation, to education. So when you think about all of these characteristics and you think about the communities where you live in or the communities that you work in that either have some of these assets or don't, you start to realize that, you know, these things are the way they are by design, that we currently live in communities that are designed for disease. And so when we look at our low-income folks and we look at our folks of color in the communities that they're in, we recognize that the poor have to pay more for food. We recognize that in low-income communities, there are many more fast food restaurants and convenience stores than there are grocery stores and kind of produce vendors. We know that the quality of foods are not equal to some of our communities with better health, and that transportation is a barrier and prevents residents from accessing some of their basic needs like food, like education. And then also, you know, thinking about media and the way in which media markets unhealthy options to our communities. And so knowing that our communities are designed for disease, how can we really counter what's in place to start reversing that trend? And really that's what we're all in this for, to really figure out what we can do to help turn this around. So then if we look on the other side of this coin, we really want to understand, you know, what is equity, and then by extension, what is health equity. So at PolicyLink, we define equity as kind of just and fair inclusion. And so equity is about the just and fair distribution of those factors or the social determinants of health, affordable housing, safe and affordable transportation, access to services, decent jobs, right? So it is about the distribution of those factors that we know that create health. So the goals of equity must be to create the conditions that allow all of us to reach our full potential. Because we know that when some places lack healthy systems and structures, that communities but also regions suffer. So then operationalizing health equity means that we're really looking to remove barriers so that every family has access to healthy food, public transportation, good jobs, and green space, or other places where they can be active. So it's really about removing the barriers for folks to be able to attain their highest level of health. And so to do that, we really start by recognizing the driving force behind systemic health inequities. Right, so we know that poor communities and communities of color lack access to safe parks and lack access to efficient and affordable transportation, have poor quality schools and education, but I think oftentimes it's hard to kind of pinpoint why. So even when when we think about kind of inequity and the systems that underlie these health outcomes and what's really driving those inequity, PolicyLink, we know that, right, the health research tells us that even when you adjust for income, you adjust for education, that racial disparities still persist. And so we really think that one of the key things that's important to acknowledge is racism. And now racism takes many forms, right? So there's individual racism, which really lies within the individual, and this is not what we're talking about. We're talking about the institutional and the structural racism, right? So institutional racism really occurs within and between institutions. It is kind of the expression of unfair policies and the inequity of opportunity and the impacts of that inequity that's really based on race, based on gender, based on sexual orientation, and that as individuals within institutions, there are things that we all can do to really either perpetuate or to kind of disrupt some of these policies. And then, you know, kind of at the highest level, which I think particularly based on conversations I've had with Jeff and Adrian, is structural racism, and this is where I think we're all in a good position to try and challenge our existing structures. So, right, structural racism really speaks to the inequalities that are rooted in our system, in our society, and really the ways in which our systems have excluded substantial numbers of people just based on kind of some group affiliation or their membership as part of a group. So this encompasses history, right? So what lies beneath the surface, and the history that this nation needs to own, and the ways in which our country has addressed race and perpetuated racism. It includes culture. So this idea that in many ways it's normal. So we have normalized and also replicated kind of racist ideologies and stereotypes. And then this idea of the interconnectedness between institutions and policies, right? That key relationships and rules across society have provided the legitimacy and really for racist policies and practices. And so just by way of quick example, I'll speak to the structural racism piece. So if you look at housing and the way in which housing has been distributed across our country and across our communities, you can see that there are lots of pockets of racially segregated communities. And so this is really a legacy of the federal mortgage policy of redlining that denied mortgages to Black folks. And that ended up resulting in racial segregation of neighborhoods and the subsequent declining property values, because when Black folks moved in or communities that Black folks occupied, the system had devalued those neighborhoods. And so the devaluing of those property values had an impact on those individuals, but it also had an impact on the place. And the result on the place was that there was a smaller tax base, right? And that smaller tax base affected school funding. And it also affected individuals' ability to generate wealth. So that's just one example that shows that the way in which a policy that was put in place at the federal level really trickled down and has impacted individuals' lives and persists today. So what does this mean for health? So this visual really depicts the relationship between kind of structural racism, the systems that we all interact with, and then our health outcomes, right? So if we kind of follow the last example through, we see that the structural racism that is present in that was present in past kind of mortgage policies had an impact on folks' access to safe and affordable housing, which we know ended up impacting tax revenue that undercut the education system. And given what we know about the connection between housing and education, that has direct impacts on health outcomes. We know that folks that tend to be better educated make better decisions. Folks who have attained higher levels of education tend to make more money over the course of their life, and that income is also directly correlated with health outcomes. So it's also important to recognize that these things are interconnected, right? That that it's not just about it's not that if you just intervened in education, then health outcomes would improve and disparities would decrease, or that if you just focused on housing, that we would see improved health outcomes. That really, this is a complex system, and then all of these things are really interconnected. And so what I want to leave you with this slide is that acknowledging structural racism as a barrier to success for some groups is not intended to minimize the barriers and struggles that all people may face and have to overcome. The point is really to recognize that there have been many laws and policies in our history that have created a disadvantage for folks of color, and that those laws and policies still have an effect on people's ability to succeed today. So that when we are doing our work and when we are really trying to shift from a disparities to an inequity or an equity frame, that central to that is a recognition of the importance of place and race, and that it is really just about being intentional and ensuring that as we think about our work, that we're also layering on considerations around the dynamics that are taking place in a given community, and also the role to which racial dynamics plays. And so this slide depicts PolicyLink's framework for building healthy and equitable communities. And so you'll see we have place and race here kind of grounding the work, and then we've got four kind of domains that we really feel have huge impacts on health. And so we've got economic environment. We've got four main environments. So there's the economic environment, right? And this is where we will see the impact that jobs and workforce development and career pipelines have on our health. We've got the social environment, and that really speaks to our social networks, our sense of community, our sense of connectedness, civil engagement. We've got the physical environment, which is kind of your access to transit, the walkability of a neighborhood, smoke-free housing and schools and parks, grocery stores, access to fresh fruits and vegetables. And then we've got the service environment, so access to appropriate health care, preventative and treatment services. And so we see all four of these environments as really being critical to advancing the health of a given community or group of folks. But you know, this is, right, that's not new. The story of race in America is an important part of our history, and it is something that I think we've all been aware of. And the disparities that we see in our communities have also been fairly persistent. So the question I think that we often get asked is why equity and why now? And the reality is that these are sensitive issues to talk about. Questions of race are still relevant, but now the inevitability of them is impacting our moral, our economic, and our structural viability as a nation, right? Because as people of color are growing, if we don't address the racial inequities that have been persistent for so long, that's actually going to start having economic implications. Because economically, in order for our communities to prosper, it's imperative to make sure that everyone can really participate and reach their full potential. So it's really helpful to just, this is not a zero-sum game. It's not about the fact that in order for one group to do well, another one has to do worse. We really are a proponent of looking at the growing diversity of this nation as an advantage, as an opportunity to advance equity, not because it's just the right or the fair thing to do, but because it's the economically smart thing to do. And so just looking at Kansas, this is a map of the nation, and I've circled Kansas. But you'll see that the map depicts the percentage of people of color in 2010. And so the darker areas have a higher percentage people of color. So the bands you can see are on the left, 0 to 20%, 20 to 39%, 39% to 59%, and then over 59%. And so this is what it looks like in 2010. Majority of Kansas, it looks like, is probably between 0 and 20%. As you get to 2020, so looking out kind of 4 years from now, we'll see that you'll see some increasing number of counties that have 20 to 40 and 40 to 60%. And then in 2030, it gets a little bit darker. And then in 2040, you start to see the diversity is increasing. And then this is a close-up of Kansas in 2040. And I'll say, it's still, the majority of Kansas will still probably not be over 50% people of color in 2040. But the fact remains that you will see folks of color increase. And so it's both about ensuring that they're being brought into the conversation, because we want to make sure that everyone in our community is a part of creating and shaping the solutions for kind of the challenges that we're facing, and that those folks are also participating and contributing to the growth of our states and our nation. And so here, the exact figure or the projection is that by 2040, Kansas will be 64% white and then 36% non-white. But if you look at 2010, that is a 14% increase, just over kind of 30 years, which I think in parts of Kansas, or just in general in more rural communities, it may feel more drastic because the growth is likely exponential. Whereas in urban communities that might already be more racially and ethnically diverse, it might not feel as stark of a difference. And so here I just wanted to illustrate kind of the difference by race we see in wage. So you'll see that in 1980, there was a $2 gap in hourly wage between folks of color and white Kansans, and in 2012, you'll see that that has doubled. So we've now got a $4 difference, and that for folks of color, you've actually over time seen a decrease threefold that of white folks. So while race is a social construct, it is a construct that we have used to differentiate people, right? It has been used to create unequal allocations of power, and it has been used to determine who gets access and opportunity. And so it has continued to really have major effects on our educational, our economic opportunities, our political, and our institutional representation, and thus our health. So our physical and emotional health, our wealth, and it exerts a great influence on how social benefits and burdens are distributed. So really, to transform our systems, we have to consider the many ways in which racism has reached into all of our lives, and find new ways to build and equity approach that really puts folks of color and low-income communities at the center of our work, because if we can get it right for those folks, we can get it right for the nation. So, you know, kind of in summary, equity matters more than ever because the face of our nation is changing and our communities are changing, and we really need to have strong communities of color who can really help to contribute to our nation's growth and prosperity. And that with rising income inequality that is also persistent, we really need to think about how we're going to bring everyone into the fold and both create opportunities to revitalize our economy where it is lagging, and then also ensure that everyone has an opportunity to be brought into that new economy. And then also just recognizing that historically low-income folks and folks of color have experience disproportionate lack of access to quality health services, so bringing it back to health and really recognizing that our health disparities are also increasing, our healthcare costs are really high, and that too has an impact on our ability to be productive and have a strong economic or strong workforce for our economy. But I think, you know, achieving equity is possible. We see examples across the nation of folks who are really taking this to heart and really thinking about how they can do their work differently. And for us, it's so much of it is about not only continuing to do the good work that we're doing through programs, but also thinking about policy, right? Because when we talk about systems, all of the systems that we name, policy impacts each of those systems, and it impacts each of the environments that I named. So the economic environment, the social environment, our physical and service environments. The Affordable Care Act is a policy that has drastically influenced our service environment, our healthcare access. We have workforce policy and funding that has gone to really think about how you engage folks that have a hard time being hired, you know, folks who are formerly incarcerated, into mainstream jobs. That has huge implications for our economic environment. Our physical environment, we've got federal policy that really dictates how dollars flow to fund transportation, right? So funding public transportation or funding for highways and byways, thinking about how policy impacts the flow of resources into our communities. And then this idea of health in all policies, right? So we know that transportation and housing and education have impacts on health. So how do we ensure that the policies that are not traditionally thought of as health consider their impact on health? So how do we connect with our colleagues and our peers in our local MPOs, our local municipal planning organizations, and our departments of transportation to help them think about what the decisions they make mean for the health of our communities? And then we add on this idea of equity in all policies, right? That our policies can either produce positive or negative impacts for folks of color and low-income folks, and that we need to upfront be thinking about the disparate impact that any decision might make. And then also just thinking about the triple bottom line. So when we get to our strategies, how is it that our strategies will be addressing people, place, and the economy? So improving health of our communities, revitalizing the neighborhoods that folks are in, and then also creating good quality jobs that offer a living wage. And so equity is both about the means and the end, right? It's about how we do business and how we work and interact with others and what we are seeking to achieve. And we really all have a role in that. And so this is just a list of a number of potential policy and environmental change efforts that really support health. Many of these are familiar to us, right? Safe routes to school, we've got increasing EBT access at farmers markets, looking to improve our corner stores and bodegas, trails and safe parks. Any one of these, however, is not guaranteed to advance equity. Right? It's on us to be deliberate about integrating equity into our processes and policy. And so health is cumulative. And poor health didn't get this way. We didn't get this poor health overnight, right? So, so building our system of health really will require us to think about how we can approach any one of these or any number of other strategies through an equity lens. And that requires us to, I think, really be reflective. So as you all think about the work that you're doing or the potential proposals that you'll be developing, here are some questions for consideration, right? So first and foremost, what inequities will you be reducing as a result of your strategy? What problem are you looking to solve? How will you deliberately focus on implementing your strategy in a way that promotes equity? So who is being impacted by the problem that you're trying to solve, and how is your strategy looking to really reach those folks? How will your strategy promote meaningful and authentic community engagement? So when you think about who is most impacted, to what extent are they involved in the planning or the design or even the implementation or the assessment of your effort? And how does the proposed strategy affect policy and our system change, right? So we know that folks have needs and that those needs are very real. And we know that there's a system at play that lies further upstream and really dictates the flow of resources and and dictates who has power and who does not have power. So thinking about your strategy, how does it affect policy and our systems? And then how does your action help to achieve greater racial and economic equity so that it really expands opportunity and access for the folks that are most impacted? And then also, what could be some of the unintended consequences of your strategy? I think it's important to not only look at what will be gained, but also what potentially may be lost or who or what may potentially be harmed. And so kind of if you had to whittle it down to 4 straightforward questions, it's these 4 at the bottom. Kind of who benefits, who decides, who leads, and by paying. It is very important to be cognizant of where is the money coming from, and are there. So, an example. This is the Evergreen Cooperative in England, and I wanted to show this example. It's a good way of understanding what we mean by kind of the triple bottom line as a strategy. And so the Evergreen Cooperative was launched in 2008 by a group of several Cleveland institutions that included the Cleveland Foundation, the Cleveland Clinic, some university hospitals, Case Western Reserve University, and also the municipal government. And basically, the enterprise launched 3 kind of cooperative employee-owned green businesses. So there's a laundry cooperative. There is Evergreen Energy Solutions, which focuses on installing solar panels. And then there's a third enterprise, which is the Green City Growers Cooperative, which is the one that I'm going to focus on. So the Green City Growers Cooperative is essentially a greenhouse, but it is 3.2 acres. This is a picture of it. It's a hydroponic greenhouse that was located on what was previously a huge abandoned lot in the middle of a very poor, predominantly black urban neighborhood in Cleveland. And today, you'll see they produce a ton of vegetables. And they mostly focus on leafy greens and herbs that are sold to nearby grocery stores and wholesale produce businesses. Now, it's for-profit cooperative that also includes 15,000 square feet of packaging space and office space. And some impressive statistics. They produce 3 million heads of lettuce and 300,000 pounds of fresh herbs a year. The cooperative provides employees with living wage and affordable benefits. And they've collectively, so not just the greenhouse, but all three green businesses have collectively created over 100 jobs with a long-term goal of creating 5,000 employees over kind of an expanded network of worker-owned firms. And then eventually these employees will become owners of the business over a period of time and share in the profits because it is a cooperative model. And the impact on the local food landscape has been pretty significant as well. The greenhouse continues to produce during the cold winter months, which is really important in Ohio. So it provides year-round jobs. And then in addition to the for-profit kind of component, they also donate 1% of all of the food that's grown to the Cleveland Food Bank. So this really hits on all of the points. It's creating jobs in the community and facilitating local wealth accumulation. It's increasing access to healthy foods both in the community and citywide. And it has taken this empty lot that was pretty much an eyesore and not doing anything for the property value of the community or use as a resource for anyone in the community, and it's really revitalized it, and that has helped to bring investment and stability to the surrounding neighborhood. And so there's equity through policy, right, and that is a strategy development. And then there's equity through process. And that is where we think about data collection and analysis, partnerships, and community engagement. So when we think about data and analysis, this is really asking ourselves, what data are we collecting? What are we using to currently understand the conditions in communities? Are we stratifying data by race? Are we looking at comparisons between counties, between different cities? And are we including indicators that reflect kind of the multiple dimensions that a given community really experiences the world through, right? So are we just collecting health data, or are we also looking at some of these other systems and the quality of the education or the transit? And that feeds into the second one, which is what indicators are you using in your analysis? So when we think about health inequities, we're thinking about the systems that underlie that community or that support that community and the extent to which they're supporting healthy decision making or not. And then kind of who is most impacted by these inequities and where are these inequities most severe. So I think when you're looking at, when you get to the analysis piece, it's really important to drill down in the data and try and get a sense of who is disproportionately burdened by a given disease, and or where are these inequities most severe? Is it in a particular part of town or the county or the community, or is it amongst maybe a particular marginalized group? And then not just looking at the negative, but also looking at the positive. So what are the assets? And how are those assets being identified? I think that one of the things I've learned is that I may have an idea about what is a positive in a community, but not being a member of that community, I may get it totally wrong, or what's usually the case, I don't name assets that the community sees as positive qualities. And then this last piece, kind of what learning has come from community residents. And so how are you engaging community to better understand how they're experiencing the world, how they're experiencing their community, what they're defining as kind of a problem or not, and what they're seeing as assets or not. So I want to give time for questions, so I'm just going to kind of move through these last slides. But this is just a helpful visual to refer back to, and it really provides, I think, good guidance when we think about what it is we can do to really engage communities, right? So when we talk about meaningful community engagement, our ideal is to be at that top level where we have the strongest impact. So we really ideally want to have community folks that are really being impacted most, to be at that decision-making level. We want them to be a part of the decisions that are being made. We want to be sharing that power with them because they're bringing the local knowledge and the lived experience that should help to both frame up the issue but also create the solutions. And then you'll see if you go down, you've got kind of decreasing levels of impact. So advisory groups where folks may provide guidance and advice to decision makers, but still they're not in a position to really be kind of weighing in on what ultimately is either implemented or supported or funded or not. You've got focus groups and town hall meetings that are kind of at the lower end, right? Those are one-time opportunities for folks to really provide input, and it's a good start, but I think we want to really try and make our way up this ladder of engagement to the extent possible. And I think the last point here is that it's not just about who is at the table, but the type of table you're setting, right? So are you setting a table that is kind of has collapsible legs, and then at the end of the engagement you kind of pack it up and you're off? Or are you setting a table that's really there to stay, that's solid, and that exists even when you're gone, and that people feel comfortable coming to even if you maybe aren't there to bring them together? And that is a big table so that, you know, there's room for new folks to come in as the dynamics of a community change and grow. And so these are just some principles for community engagement. Recognizing that processes have historically excluded and marginalized low-income communities and communities of color. And so when we really go to meaningfully engage folks, we want to empower residents, and that this is about creating a space for people to really step into and exercise their sense of power. We also want to build capacity for folks to engage at a high level. And so what does it take to get folks to a place where they can really engage in conversations at a high level and understand both their experience but also the systems that you all are operating in, and how decisions get made, and the realities of kind of compromise and trade-off. The third principle is really prioritizing community knowledge and concerns. So when we think about data and what is considered valid and not, I think it's important to really recognize that community experience and community knowledge is just as important, and that we need quantitative data, but we also need kind of the lived experience to bring meaning and nuance. And that this isn't going to happen by accident, right? So we have to resource this. We have to target resources to support engagement, and that engagement needs to be ongoing because these issues are deeply entrenched and require ongoing effort. And then also really creating a space for mutual learning and feedback so that it is reciprocal, so that in kind of our effort to really meaningfully engage community, we're getting to a point where we're building partnerships. And so the considerations when really engaging any sort of community is acknowledging the power dynamics, right? If you have the money and they are looking to get the money, there's a power dynamic that exists, and I think naming it is just really the first step. So to address issues of race, culture, and class, because these will come up, and again, it's just about being intentional and deliberate and recognizing that these issues are real, and being open to working through any tensions that may arise, to craft framing and messaging that really enables people to participate and is inclusive, and be willing to slow the process down, because particularly when engaging community folks, they have other jobs, they have full lives, and the engagement with us is in addition to all of that. And then lastly, to monitor and evaluate our progress and impact, right? So to first do no harm, to really think about how we're doing our work and the potential positive or negative impacts that it's having. And then this is just a quick example that I think kind of encapsulates all three of these points around process. In Worcester County, Massachusetts, which is predominantly white, it's like 88% white, small African American, Native, Asian, and Latino population, they really formed a stakeholder advisory committee, and a foundation in this instance really served as the liaison to the committee. But basically, there was a community health needs assessment that needed to be done, and they wanted to approach the assessment in a way that really engaged multiple members of the community, that was collaborative, and resulted in a plan that really put equity up front. So they conducted key informant interviews with a number of community actors and ended up engaging over 1,700 individuals who provided input. Based on that, they really outlined their equity priorities, and health equity ended up being included as a major domain for the Community Health Improvement Plan. And then after they did some strategic planning and included, again, stakeholders from community, and then really followed through and reported back to the stakeholders. And then have since, I think, engaged folks in the implementation of the strategy. So when you think about policy, the folks in Worcester leveraged the Community Health Needs Assessment process, which is a requirement of the Affordable Care Act, and used that as an opportunity, used that needs assessment as an opportunity to really engage everyone in the community around a plan for health, a plan for improving the health of the community. And then as a result, right, they've got folks engaged, activated, motivated, and have created kind of a base of people that are really interested in sustaining kind of the effort and attention. And so I'll conclude by saying that I think whatever it is that you all are doing, whoever you're working with, you really want to just be disciplined in your execution, keeping these issues of race and place at the forefront, and trying to be really diligent about asking these questions of who pays, who decides, who leads, and at the forefront of the work that you're doing. And then also just holding all of ourselves to a new level of accountability. We are accountable to the communities that we serve, and it's not just about it's about working with them. And so how do we do that in a way that lifts them up and really gives them kind of some power and has them squarely seated at kind of the table where we're making decisions. We want to align our investments with our systems. So this is back to the policy and systems change piece. Really stretching outside of our comfort zone, moving to the fourth point, and going from programs to also thinking about policy and the way in which our systems are at perpetuating inequities, and then also just being less tied to issues and being really more cognizant of our tactics and our processes. So if we kind of, how do we meet people where they're at and really work from a place of kind of mutual understanding and respect. And with that, I want to thank you.
Thank you, Stephanie. I think you've given us a lot to think about. As many of you know, I've been urging the healthy communities leadership teams to think about how they can put a health equity lens over the next several months on some of the work that they're doing in the community, and so I would urge you to think and work with the TA providers on really being more deliberate about experimenting with some of these ideas that Stephanie has shared with us. So with that, do we have any questions out there? Right now, Stephanie, we don't have any questions.
No worries. I know it's always hard to interact over webinar, but folks should feel free to, if you get questions after the fact, after folks have had time to digest, I'm happy to answer any.
Sure. We'll be talking about this a lot more. I think we have another convening this fall, and we'll be talking about that. Looks like we got something here. HCI teams struggle to add members to the community at the community level. They have a cohesive group and patterns. It's hard to break out. What can we do to promote this?
So is the question about increasing the level of representation at
yeah, I think that's
by Asian Pacific Islander community?
Yeah. Yeah.
Okay. Okay. You know, my recommendation would be to identify leaders in that community and engage them and have them, once you build a relationship with them, let them kind of lead and bring in others from the community. I was working with a group in Arkansas, and there was an immigrant community they were working with and finding really hard to engage them. And they tried a number of things. They tried kind of doing, I think, more traditional outreach and flyering and going to the community meetings that community held, and we're still struggling. They tried working through some of the youth groups or the after-school programs and still finding it really hard. And ultimately what ended up, I think, working was that they identified a leader in the community, built trust with that leader, and then kind of took a step back and the trusted that leader who was from the community was then able to speak to her folks and get them to really engage with this organization. And so I think two lessons. The first lesson is just, you know, be diligent and keep doing what you're doing and keep trying to reach out, because I think that is part of building trust when people see you being persistent. And then the second suggestion is really just around identifying, I don't like the term gatekeepers, but identifying those folks that you can start to kind of maybe build trust with one-on-one, and then figure out how they can be a part of your engagement and outreach strategy.
Okay, we've got two more questions. See if we have just a little bit of time here. The first one is, do you think there's any drawback to focusing on income disparities over racial disparities? Sometimes people conflate race disparities with income disparities, but I've also heard that they oversimplify the issues. Any thoughts, reactions?
So I actually think that you don't want to oversimplify. I think it's a both and, that you want to focus on income and race, because they are so interrelated. And I think that because you all are working in very specific communities, the key for you is to just understand kind of what's happening with income in your community, what's happening with race, and what's happening at the intersection of income and race. And I can't promise it will be clean, but I think that you would be remiss if you just focused on one over the other.
Great. We've got another question here. I think it's a really good question that we can all think about as we go forth. Thoughts on incorporating health equity into all current work groups of a community health coalition, or to create a specific work group to lead this work? we are about to make a specific work group, and this webinar has been very informative.
That's a really good question. So I think that oftentimes what I've seen is that people do have a work group dedicated to health equity, and that the challenge is to just ensure that that health equity work doesn't get siloed and seen as being other, because we know that it needs to be a part of all of the work. And so one way to do that is to create a work group that's really focused on digging deep in these issues and ensuring that members of that work group sit on the other groups, so that they're listening, and also they're listening for things, and they're also bringing what's being discussed in the health equity work group to those spaces, so that you kind of have some cross-pollination. And then I think over time you can start to think about how you ensure that equity is part of the conversation in each of those. I think it's a both and, just because it's important to have a dedicated space, particularly when you all are trying to figure out what it means for your work to really go deep in this. And I think it's good and important to have some key principles or questions that every group asks themselves to make sure that they're being thoughtful about how they can apply an equity lens to the work.
Great. We've got one more question, but before we do that, I want because some people we may lose some people. I just wanted to make sure that people understand that this will be on the SharePoint site. We'll put this on in the next couple of days. You'll be receiving an email shortly wanting you to evaluate the webinar. We would really appreciate some great feedback on that. And then the semi-monthly reporting needs to be is due July 15th, so don't forget. And make sure on your calendars, the October 27th and 28th are HCI convening this fall. With that, let me go ahead and pose this last question. I think it's another good question. If we wanted to pick a starting point from among the 4 approaches to address health equity, where would you recommend we start? Strategy development, data collection, analysis, partnerships, or community engagement?
That's a great question. This is probably not going to be a satisfactory answer, but I think it depends on where you are in your work. If you're at the beginning, I think you really want to be sure that you are, you want to really look at how you've assessed the situation. Like, how have you defined the problem and who's been a part of defining that problem, right? I think that if you're in the middle of the work, you really want to take a step back and say, okay, who's at the table? Who are we currently engaging? What table have we set? Is it welcoming enough? Have we gone out and really tried to engage those groups that are hard to engage? And then also thinking about who you're doing the work in partnership with. Are you doing it alone? Should you be including other folks in that? Is there someone doing similar work and you guys have inadvertently created these maybe parallel work streams? And then strategy development, if you're at the point where you are, you are developing strategy, I think that's a good time to ask yourself questions about, to the extent to which you're addressing the triple bottom line. And I will say that I think, I think the last slide in my kind of conclusion, in my considerations, I think you should not be afraid to slow down. So if you are, regardless of whatever point you're at in your work, I think it's okay to stop and take stock, and if you need to go back to data collection, go back to data collection. If you're already thinking about strategy development, but you realize, ooh, we didn't have someone at the table for those early conversations and we really need to be engaging them, go back to that. It really depends on where you are, but I don't think it's ever too late to kind of go back.
Great. Well, Stephanie, that's been a very informative webinar. The one thing that did remind me, Charlie asked that question, and as far as a place to start, I would like to think about going back to one of the areas that we talk about around our leadership development work is really trying to stay in diagnosis for a little bit longer. And so I think that leads to kind of the data collection as well as the community engagement.
Yeah.
So really trying to diagnose where you're at before you develop the strategies. So anyway.
That's great.
Anyway, Stephanie, I appreciate it. And with that, I think we'll go ahead and call it a good webinar.
Thank you very much for having me.
Thanks, everyone. Bye.